Dear APA participants, on behalf of our Pancreas 2000 group, I would like to present our meta-analysis regarding venous resections in patients with pancreatic cancer. As we all know, patients who can undergo a curative resection have a better prognosis compared to a palliative treatment setting. But what of the patients with suspicion of venous infiltration? Is it safe and feasible to add a venous resection to pancreatic surgery? To answer this question, we aim to compare the mortality and morbidity of pancreatic resections with and without venous resections. Therefore, we performed a systematic review and meta-analysis. We finally included 32 articles which described over 2,000 pancreatic resections with venous resections and over 5,000 without. When we compare the patient characteristics, we see that the baseline characteristics are comparable, and most of the operations are pancreatic duodenectomies. When we come to the operation and pathology details, patients undergoing a venous resection have a longer operation time, more blood loss, larger tumors, more R1 resections, and more lymph node involvement. Furthermore, about 2/3 of the patients who can undergo a venous resection have true pathological infiltration. When we compare the complications, we can see that the overall complication rate is comparable, but it is borderline significant. Patients have more postoperative bleeding and a higher percentage of 30-day mortality. The 1, 3, and 5-year survival is worse for patients undergoing a venous resection. However, the pooled multivariate hazard ratio for overall survival is not significantly different, so perhaps the effect on survival is caused by the pathological and surgical differences instead of the venous resection itself. In conclusion, more than 2/3 of the patients undergoing a venous resection had true venous infiltration. Despite of this, with venous resection, an R0 resection was possible in 63% of the patients. As the pathological results differ between the two groups, it is difficult to compare the true effect on survival. However, patients undergoing a venous resection have worse outcome compared to patients who do not require a venous resection. Finally, in the era of neoadjuvant therapy, these differences might be reduced and the prognosis is still better compared to palliative treatment. Therefore, if an R0 resection can be expected, the venous resection should be considered. Thank you for your attention, and if you have any questions, feel free to send me an email.